Hello everyone, my name is Gerald Gatlehner and I would like to welcome you all to the method seminar today. These seminars are organized between the Danube University here in Austria, the Schepp Center for Health Services Research at the University of North Carolina, and RTI International. And of course, as always, we welcome individuals from other organizations to attend. So before I introduce today's presenter, I would like to remind everyone to please mute your microphones while the presentation is going on. Also, I would like to remind everyone that we record these method seminars and then publish them as slide-casts on our website. However, we do not record the discussion after the presentation. So today's method seminar will be given by Dr. Tom Trikalinos from Brown University. Dr. Trikalinos is an Associate Professor of Health Services, Policy and Practice and the Director of the Center for Evidence-Based Medicine at Brown University's School of Public Health. He works on methods and applications of evidence-based medicine from analysis of individual participant data to decision and economic modeling. Dr. Trikalinos is widely published as in the medical literature as well as in the mathematical and engineering literature. Of relevance to this seminar today, Dr. Trikalinos and his colleagues also work on methods for assessing comparative test accuracy, including modeling of multiple tests and network meta-analysis of diagnostic tests. So thank you so much for being with us today, Tom. We are looking forward to your presentation and we will now hand over to you and you should be in control of the screen now.
Wonderful. Thank you very much, Gerald. And it is an honor to participate to your seminars and to have this discussion with you. I will take control and let me ask you: are you able to see the title slide only?
Yes.
Wonderful. So we are going to discuss today, and I think that you should feel free to interrupt me and ask questions as we go forward. We're going to discuss meta-analysis of diagnostic test data, and we will mainly focus on the typical meta-analysis approaches when we have a single test. My plan is to go through this discussion and then if we have some time to do a demonstration of the Open Meta-Analyst software that implements the methodologies that I will describe. And of course, as I said, feel free to interrupt me. This is an obligatory slide that I have nothing to disclose. I should not be telling this crowd what meta-analysis is, and I really will not stay on this slide. In the same fashion as we are talking about meta-analysis of interventions, meta-analysis of genetic data, of prevalences, of risk factors, we are also talking about meta-analysis of diagnostic test accuracy. And when we are studying medical tests, the study of the problem of how well tests perform, or more accurately, how useful tests are in clinical practice, is more complex than the corresponding questions that one can ask when one deals with interventions. And the complexities arise from the fact that testing has many different uses. So we use tests for diagnosis, screening, patient monitoring, treatment guidance, and prognosis. And the tests are used in different roles in the clinical management of people. One can use a single test for each one of the 5 potential uses on the left-hand side of the screen, but one could also consider a test to be a replacement of an existing test, perhaps to be a triaging test before to decide who will receive a subsequent testing procedure, especially if the subsequent procedure is, let's say, invasive or expensive or dangerous. Or it could be an addition to an existing diagnostic workup. And the combination of the 5 potential uses and the 4 potential rows of tests makes it a bit more complex to evaluate medical tests in a clinical setting or in a public health setting compared to interventions. And to discuss this in a bit more detail, when one wants to assess the utility of medical tests, one should keep in mind that the value of testing is determined by the ability of tests to affect patient-relevant outcomes. And in most cases, testing itself does not have direct effects on patient-relevant outcomes. In most cases, the impact of testing is indirect. Testing will affect diagnostic decisions and treatment decisions, and these will eventually determine outcomes. So the treatments that will be chosen based on testing will affect the outcomes. And therefore, when we are assessing the utility of medical tests, we should think about assessing really the utility of patient management strategies, of test and treat, or test and intervene management strategies. This is not to say that testing in itself does not have direct health or health impact, because tests have impact on cognitive, on emotional, and other outcomes, and sometimes they have direct risks and harms. But for the most part, the utility of medical tests is evaluated with keeping in mind that the test is embedded in a whole patient management strategy. So because of that, it's why the 5 different uses and the 4 different roles of tests have intricacies that come up when we consider the whole test and treat management strategy. However, in our seminar, we are not going to talk about the interesting question, which is how you assess the utility of test and treat strategies. What we are going to talk about is a peripheral question, or if you will, a sub-question or a sub-problem that one has to more often than not deal with in order to then proceed to evaluate the utility of testing in general. And this is the question that has to do with test performance. And this is where meta-analysis of test performance or of test accuracy comes in. And we're talking about the meta-analysis of metrics such as the sensitivity of tests, the specificity of tests, or meta-analysis of predictive values, positive and negative predictive value, likelihood ratios, and so on. And when you have that synthesis about the test performance or test accuracy, then you could use that information together with other information, perhaps information about the effectiveness and safety of treatments, and the likelihood of patients adhering to treatment and testing recommendations, to piece together the puzzle that is about the clinical utility of testing. So all we need to, in most cases, to do a meta-analysis of medical tests is a 2x2 table, and it's the 2x2 table of classification or cross-classification of test results and of disease. There are tests that are continuous, but for the most part, tests have to be dichotomized, or test results have to be dichotomized or categorized into several categories, and based on these categorizations, clinical actions are taken. And the simplest case is when the test result is categorized into a positive test result and a negative test result. So this is a 2x2 table. It should be, I'm sure that you have seen such tables many, many times. And on the vertical, we have the disease, the disease status, and this is commonly asserted or defined by the results of a reference test. And for the most part, and for this discussion, we will consider the classification in columns to be error-free, meaning that the reference test does not make any errors in the classification of the disease, or that if any errors are made, these errors are negligible. This is, in many cases, a very reasonable assumption, and in some cases it may be an assumption or a starting point that is a bit tenuous. If this is the case, then there is another discussion that we can have, and perhaps we can visit the case of an imperfect reference standard in our discussion. However, if we start from the point that the reference standard is error-free, then we are typically summarizing test performance by two metrics: the sensitivity, which is the probability that the test identifies those who have disease, this quantity is called sensitivity, and as you can see, it's working in columns. So it's to estimate it, you divide the true positives by the number of people who have disease, that is true positives plus false negatives. Another quantity that we use is the ability of tests to correctly identify those who do not have disease, and it is estimated by the ratio of true negatives divided by the total number of people without disease. And it is most often that we use those two quantities to characterize the accuracy of tests or the performance of tests. So if you think about it, compared to the case of a treatment where we characterize the difference between the outcome frequency in the treated and the controls by a measure of treatment effectiveness, such as the risk difference, the odds ratio, or the risk ratio, in the case of diagnostic tests or tests in general, we have two metrics. We have sensitivity and specificity. And in a given study, these two metrics are a pair, and they are connected between them. They are related between them because of what is commonly referred to as the threshold effect. And the formalization of the threshold effect and the formalization of the relationship between sensitivity and specificity can be stated mathematically, but it is very obvious through a cartoon or a schematic. And the way that the threshold effect works is that if you have people with disease, which is the red distribution here. I've drawn distributions that are bell curves, but that is not necessary in the mathematical exposition. The distribution of the people with the disease is the red, the distribution of the people without the disease is the black, and there is supposed to be a test measurement that could be a continuous measurement, and it separates, if you will, the diseased and the non-diseased. If the two distributions were to overlap, then the test could not distinguish the distributions and it would be a useless one. In practice, one draws a threshold, one takes a value of the test measurement and says that below that value we will consider that the test indicates absence of a disease, and above the value the test indicates presence of a disease. Immediately any threshold results in misclassifications. So above the line, for the red distribution, for those with the disease, you see that the test identifies a threshold there drawn would identify the majority of the people who belong to the disease distribution, and these are the red highlighted area, and they are the true positives. On the left-hand side of the red distribution, you see that we have several people who are below the threshold, although they have the disease, and these would be false negatives. In a similar fashion, for the no disease distribution, above the threshold we have the false positives, and below the threshold we have the true negatives. And as we slide the threshold upwards, the relative areas of true positives and true negatives change, and this is this means that as the threshold goes up, the sensitivity goes down. That is, the ratio of the true positives compared to the whole area under the disease curve goes down, and the ratio of the false positives compared to over the area of the black curve under the black curve goes up. So the false positive rate, and which is 1 minus specificity, and the true positive rate, which is sensitivity, are related, and they are inversely related as the threshold slides. And by recording the pairs of sensitivity and specificity for various threshold values, we construct what is known a ROC curve for a single test. So this is a brief introduction to how the relationship exists or is being generated, arises between sensitivity and specificity, or between true positive rate and false positive rate, which is 1 minus specificity. And I am sure that you have seen those curves on an ROC plot or a square plot many, many times. So when it comes to meta-analysis of medical tests, our goal is to summarize the relationship between sensitivity and specificity in a group of studies. And because sensitivity and specificity are not independent quantities, across studies they are related through the threshold effect that we kind of schematically exposed. We have to analyze those two quantities in a way that takes into account the correlation between sensitivity and specificity. So this is the fundamental reason why meta-analysis of diagnostic tests is different than meta-analysis of interventions. In the meta-analysis of interventions, we have typically a single metric, a single effect size, an odds ratio, say, that we want to synthesize across studies. In the meta-analysis of diagnostic tests, we have two quantities, sensitivity and specificity. And these two quantities are not independent, they are interrelated. So a meta-analysis of diagnostic tests has to fulfill some desired characteristics. A method has to check off some desiderata in order to be theoretically motivated to describe the relationship between sensitivity and specificity. And these are that it has to be able to handle two outcomes. It has to be a bivariate method. It has to be able to account for a threshold effect across studies, that is, account for a correlation between the sensitivity and the specificity across the studies. And also, it has to allow for between study heterogeneity. So it has to be a methodology that allows for random effects. And the the current state of things is that for the simple meta-analysis of medical tests, where we have one test at a time, and where our gold standard is considered to, our reference standard is considered to be a gold standard and error-free, we have two ways of approaching the synthesis. And one of them is typically referred to as the bivariate model, and the other is referred to as the hierarchical summary ROC curve model, or the Ratter-Gatsonis model. So I will try to expose the intuition behind the modeling, and then I will say that those two approaches essentially try to synthesize studies in different ways, but they are fundamentally related between them. So when we are meta-analyzing medical tests, as I said, the goal is to summarize the relationship between the average sensitivity and the average specificity in a group of studies. And once we characterize how the overall sensitivity and the overall specificity
Tom?
relate, yes?
Sorry to interrupt you. So could you, someone just came up to me, could you please explain the threshold effect one more time?
Oh, absolutely. I will go back to the cartoon, if that is okay. So let us say that the test measurement is a measurement of blood glucose, and let us say that we want to distinguish between people who have insulin-dependent diabetes and people who are without insulin-dependent diabetes. Now, the red curve would be people who have insulin-dependent diabetes, and in some fashion, in some way, they are defined perhaps because we know that these people take insulin. And on the left-hand side, we have other people. Now, when our fasting blood glucose is very low, when it is on the left-hand side, okay, among people who have diabetes, you expect that their fasting blood glucose may be higher than people who do not have the disease. And let's pretend that it's a work with me example. And of course, if they are treated, the measurement will normalize, but it's kind of to get an intuition. So of those people who have diabetes, some of them would have very high measurements, some of them would have smaller measurements, but on average, the distribution of the diabetics would be in higher values compared to the distribution in non-diabetics. Now, if I take a measurement, then if I examine people, then I take a population of people and I will measure them, and in order to then classify them into diabetics and non-diabetics, I would have to dichotomize my test measurements. So my blood glucose measurements may be continuous values from a low value to a very high value. But in order to say, based on that measurement, I believe that you are likely to be diabetic, I have to take a threshold. I have to take a value, perhaps it would be, I don't know, 126, whatever units this is. And above 126, I would call you diabetic, and below 126, I will call you a non-diabetic. So if I choose the value of 126, depending on whether this value is low or high, I have a trade-off. I have a trade-off between being able to identify all of those, or the majority of those who have the disease, but at the same time I would call as diabetics people who do not have the disease, simply because they are above my test's threshold. Is this explanation till now working?
Yeah, I think so. I think so. And are there any other questions? No, thank you.
Yeah, so the idea is then that if I were to choose another value, let's say 130, I would classify different proportions of people as with disease and with not disease. And by choosing a different threshold for the same test measure, for the same test, MIP, which is the fasting blood glucose, I would have different proportions of my population classified as diabetics and non-diabetics, and these would correspond to different sensitivities and different specificities. The idea is that sensitivity is the red area, the red highlighted area, divided by the total area under the red curve. It is the true positives divided by the sum of true positives plus false negatives. True positives is the red, false negatives is the white portion of the red curve on the left-hand side of the threshold. And specificity is defined in the population of the ones who do not have the disease, and 1 minus specificity is the false positive rate. So sliding the threshold up and down, I get the ROC curve, and the ROC curve is essentially what is the pair of sensitivity and specificity, or what is the pair of sensitivity and 1 minus specificity. It's the same thing, it's just that the axis is reversed for different thresholds. So on that curve, each point, each dot is supposed to be the pair of sensitivity and specificity that you obtain for a different threshold chosen in the previous schematic. And the idea is that if I am to meta-analyze medical tests, I have to summarize the sensitivity and the specificity of the test. But as we just saw, in different studies, people may have adopted different thresholds. So this means that exactly the same ROC curve, if I may go back to the ROC curve, the idea is that different studies may have chosen different dots along that curve because the investigators defined different thresholds. So although the underlying ROC curve is identical or could be identical, one study could be, let's say, the second bullet from the left, another study could be the fourth bullet from the left, and another study could be the second bullet from the right. The pairs of sensitivity and specificity describe essentially the same diagnostic performance, the same test, but because different thresholds have been chosen, they are all over the place. So in some sense, when we are doing a meta-analysis of medical tests, what we are trying to do is we are trying to understand this underlying curve. But we have only a couple of points from each study, or only 1 point from each study. So let me jump to this schematic and say, let's pretend that I have 5 studies, and I want to synthesize or meta-analyze those 5 studies. So those 5 studies are represented by 5 dots on the sensitivity and specificity, or sensitivity and 1 minus specificity plot. And my task is to say, what can I tell about the performance of the test on average? So in order to summarize those 5 studies, ideally, I would like to know, or I would like to understand what the underlying ROC curves are. Because if all the points were to lie on the same underlying ROC curve, then I have a different image compared to points lying on different ROC curves. So when I have in front of me 5 studies, it is possible that those 5 studies belong to 5 different ROC curves that look like these in slide 19. And because I have only one point from each study, I have only one threshold for which the pair of sensitivity and specificity is reported for each one of the studies, it's impossible for me to know what the underlying shape of the curves is. So these 5 studies may correspond to an underlying set of curves that look like this, or there are 5 studies that could correspond to very crazy shapes of underlying ROC curves. And I just showed another set of 5 studies. These are fictitious data that I just create to show that when I have in front of me just a group of 5 studies, and ideally I want to know what is the underlying ROC curve that goes through each one of the 5 points, it is a problem that I cannot identify. It is a problem that I cannot solve. And it could be that the points are lying on top of very symmetric curves, or it could be that the points correspond to curves that are non-symmetric and are different.
Excuse me, Tom, that I interrupt again. What is the effect of prevalence on this? Is there any effect at all when prevalence, for example, is very low?
That's a good question. Now, I will give you the theoretical answer that says that in theory, because sensitivity and specificity are so-called conditional probabilities, they are conditional on whether you have the disease or you do not have the disease. In theory, sensitivity and specificity are independent of prevalence. And therefore, one could synthesize or one could consider studies on the sensitivity and specificity plot independent of the prevalence of the disease in the individual studies. In practice, we know that this is empirically not always the case, not because the theory is wrong, but because some of the assumptions that the theory relies on are violated. In practice, if we have studies that are in a screening setting, it appears that investigators tend to choose thresholds that are on the left-hand side of the ROC curve. And so for screening studies, you would probably see the points being gathered closer to the vertical axis that says sensitivity, so where the curves start to go up. And in other settings where the prior probability of the disease is different, the investigators may have chosen different thresholds. But strictly speaking, the analysis is done in terms of sensitivity and specificity exactly to take out the prevalence from the equation. Does this address your question?
Yes, absolutely. Thank you.
So when I have a collection of studies, there are 2 ways that I can describe those studies. So a meta-analysis gives us a summary that tries to describe how the individual studies, what the individual studies say. And when I have a collection of studies, I really have 2 ways. One way is to say that I will calculate a center of gravity. I will calculate a summary point that describes what the studies look like. And I'm going to rush forward to give you to show you what a summary point looks like. So one summary that I can calculate is a summary point that says all of these studies that I have in my meta-analysis, and these are 29 studies on CT for non-small cell lung cancer. All of these studies can be summarized with the square point. So there is a summary sensitivity and a summary specificity that describes the scatter of the studies on the square plot. Another way to summarize studies is to say it's not possible to use a single point to describe the scatter of studies, because the scatter of studies is quite large. So I'm going to use what is known as a summary ROC curve, and the summary ROC curve is the black line that describes how the summary sensitivity relates to summary specificity across these studies as we walk along different values of summary specificity and summary sensitivity. So when I have studies, I have really two summaries that I can use. One is a summary point, and another one is a summary line. And all the idea in meta-analysis of diagnostic tests is how to calculate these two summaries. Is that intuitively understood?
Hi, it's Kylie here. I've got a question for you. So when you say that you do a summary and then you've got a summary point, and presumably there were different thresholds in the study, how would you know for what threshold that point is valid?
You would not know, and this is why many people have difficulties with a summary point, and this is why we're talking about different summaries. So the whole goal of meta-analysis of diagnostic tests is to summarize how the data look like, but if you use a summary point, then you have the difficulty that the summary point would not have an interpretation that is clear and easy if the studies have used different thresholds. A summary point may be meaningful if all the studies have reportedly used the same threshold, and if all the studies, let's say, are very close to each other on the plot. If the studies have different thresholds, then it is difficult to interpret a summary point. You can always calculate it mathematically, but what does it really mean? So you would probably resort to some sort of a summary line that would say for different thresholds, different values of sensitivity correspond to different average values of specificity. So I think that your question is really the most central one. It's not the same as in a meta-analysis of efficacy studies where we are saying this is the summary odds ratio and we can kind of understand what the summary odds ratio means. Here it's a bit more complex because we have two quantities, sensitivity and specificity, and because there's the threshold effect that describes how sensitivity is traded off for specificity in some sense, and the other way around. I am going to suggest that I will refer you to a paper that we wrote in the Journal of General Internal Medicine that talks about summaries for diagnostic test data, how to summarize diagnostic test data. And there is a discussion about the summary point and the summary line in the sense that these are two possible summaries that you can generate, and each summary may be meaningful in some situations but not as helpful in others. And there are some situations where knowing both summaries and generating both summaries makes sense. And that piece is written in English and not in math.
Thanks for that.
Yeah, so I think that we could always say, you know, this is the meta-analysis of diagnostic tests. You can generate a summary point and that's it. But I think that there are deeper issues about the interpretation of a meta-analysis of diagnostic tests that we have to be careful about, and these are subtle. So thinking about it again, and because we have not too much time left, I will kind of say, if I'm faced with a meta-analysis of 29 studies, and here they are, I say it makes sense to me, it makes sense to use a summary point to calculate, to summarize those studies, describe the scatter of those studies. Then what I can do is I can use the so-called bivariate model, and the bivariate model is really a simple model that works in two parts. The first part is the observational part of the model, and says that within each study, and by within each study I say the formulas have an I as a subscript. Within study I, the true positives, the number of true positives, are distributed binomially with a probability that is the sensitivity in that study I. And the same for the true negatives. They are distributed binomially with a true parameter that is the specificity in that study I. And then across studies, we have a structural model that describes how the sensitivity and the specificity, or to be more accurate, a function, a logistic function of the sensitivity and a logistic function of the specificity, how they are related. And usually we say that they are related following a bivariate normal distribution that has some parameters that are shown in the equation. I'm going to try to give it to you schematically. And the schematic says that if I move in the logistic space, you will see that the sensitivity and the specificity have values that are spaced, that are logistically spaced. You see that from 0.03 on the vertical axis, you go to 0.2 and then to 0.4, but the distance is not the linear regular distance. The distance is the distance that corresponds to the logistic transformation of sensitivity. So in that logistic space, the relationship between sensitivity and specificity across studies is supposed to follow a nice elliptic contour, a nice elliptic distribution. And the means of that distribution are the means of sensitivity in the vertical axis, or mu A, and mu B, the mean of specificity. And the correlation between sensitivity and specificity describes how narrow the ellipse is and how slanted the ellipse is. And if I move from the logistic space back to the normal, to the usual probability space, where from 0 to 0.2 is the same as from 0.2 to 0.4, that nice elliptic distribution is transformed to this liver shape. And we can use that liver shape to describe the scatter of our studies. And the square is the mean sensitivity and mean specificity. The dashed line, the dashed contour that is immediately around the square is the 95% confidence area for the summary point. And then the other dotted line, which is much broader, is the so-called predictive distribution of the mean, and it is kind of there to show how the studies are expected to scatter according to the bivariate model. And so by using these modeling assumptions that the shapes are nice in the logit space, or in the logistic space, we can create the summary point summary version. And the hierarchical summary model that creates a curve is also a complex regression. It's a complex nonlinear regression. I'm not going to explain the regression here, but the idea is that there are some parameters in the equations, and these parameters are the accuracy, the thresholds, and the shape. And the thresholds describe how we move along the line. The shape describes how symmetric or non-symmetric the line is, and the accuracy describes how close the line is to the upper left corner, which means that the tests are going to be more accurate. And one can obtain the summary curve, and this is the summary curve that describes how the average sensitivity and the average specificity change for my collection of 29 studies. And it may be arguably here the summary line kind of offers a more attractive description of the studies that I have in front of me compared to the summary point. The thing is that the summary line and the summary point are two different summaries that I can give for the same modeling of the data, and there is a proof that that when the covariates that I'm using are the same, or if I'm using no covariates at all, the bivariate model and the hierarchical summary HSROC model are essentially the same analysis, but summarized in different ways. So I am going to proceed with some comments on the interpretation, some points that are not very subtle. So one point is that one might be tempted to generate a summary point by just summarizing sensitivity separately from specificity. So one could do a meta-analysis of sensitivities, and that would give a summary sensitivity ignoring the specificities, so not according to the bivariate model. One could do a meta-analysis of specificity ignoring the sensitivities, and then say that where those two lines meet is going to be my summary point. But this summary point is systematically different, and it's always to the right-hand side and lower than the summary point that we obtain when we synthesize sensitivity and specificity, accounting for the fact that they may be correlated across studies. And this is why a separate meta-analysis of sensitivity and a separate meta-analysis of specificity is not recommended, because it ignores the correlation between the two quantities, and it can give quite different results. Now, here the results are not very different, arguably, although they correspond to a 10% difference in sensitivity, in specificity, and roughly 5% difference in sensitivity. Another thing is that the summary point can be seen as the center of gravity of the synthesized studies. And it may be more helpful or more meaningful if the scatter is not extreme, but in general, in meta-analysis of diagnostic tests, we have a large scatter. So, for example, a summary point is probably meaningful in this example, where all the studies are around the same area. This is KRAS for anti-EGFR treatment in colorectal cancer. But it may be less meaningful when you have this example, which is on pap test. And you see that the studies are scattered from the left to the right of the whole plane, and arguably it's better to use a line, because a line is a more honest representation of the image that we get from the studies. The interpretation of summary lines is not straightforward either, in the sense that what the summary line does is that it describes the observed relationship between the mean sensitivity and the mean specificity. And when you estimate that line, it's not necessarily the case that you can use it to define a threshold, to suggest a threshold for use in clinical practice, because the thresholds that are implied by the line are implicit, and they are latent variables. They do not correspond to thresholds that exist in real studies. So, for example, you see here an example from serial measurements of CKMB for acute myocardial infarction, and we have plotted on the plot. We have indicated the number of hours at which the latest measurement has been taken. So, if you have measurements that are taken early, like in the first hour, which is the lowest point that has sensitivity 0.4, compared to measurements that have been taken late, the diagnostic ability changes. So the line kind of describes how sensitivity and specificity change according to when the latest measurement was taken. And you see that the numbers increase as you go from the left-hand side of the line to the right-hand side of the line, but you cannot necessarily pinpoint that at some particular part of the line or some particular point of the line, the threshold or the number of hours is X. So it's kind of an implicit description, and arguably not that useful for clinical practice. So summary lines can describe how sensitivity and specificity are traded off on average, but they're of little use to practice in healthcare professionals. They can identify whether a test has potentially clinical value, but they cannot be used to compute the probability that a specific set of probabilities that you would need to put in a decision model to evaluate the clinical utility of medical tests. And a third point that is very important is that all of these discussions that we've had are about diagnostic tests that are about a single diagnostic test. But what we should be wondering is how to do an analysis, a comparative analysis, for the comparative accuracy of medical tests. So all these analyses that I described are non-comparative, are about one single test, and it's as if you were talking about a treatment having only a single-arm study. And it's like clapping with one hand because you do not have the comparator. And in order to create clinically useful conclusions, invariably, in the absence of comparative studies, you have to make assumptions about how the test is going to be used in clinical practice and what the sensitivity and specificity of that single test implies when comparing one test and treat strategy with a test and treat strategy for an alternative test. So an area of research is how do we do meta-analysis of comparative test accuracy, which means how do we analyze studies that are comparing head-to-head to different tests and perhaps incorporating information from single test studies. So it's a family of projects that we are working on. We have published several papers on that already, and it's kind of related to, if you will, network meta-analysis of diagnostic tests. So overall, the key idea is that to address the utility of medical tests, one has to link testing results to downstream effects, and in order to do that link, one needs to estimate the summary sensitivity and summary specificity in a collection of studies. And in order to do that, you need to use advanced methods that are very different from the methods that we use in the typical meta-analysis of single effect sizes, of odds ratios, and so on. While these models are complex, however, they are very easy to run in existing software. And I will very quickly, unless I hear otherwise, Gerald, I will very quickly demonstrate how to use Open Meta-Analyst to do such an analysis very, very quickly.
Let me just ask, are there any pressing questions? No? Yeah, that would be great.
So there are several packages out there that, so in Stata there is a package called MetaDX or MetaND that does the analysis correctly. In SAS there exist some macros that I'm not familiar with, but I know that there are. And in R there are packages that can do the meta-analysis correctly, but all of these require some programming and some analysis. So Revman, for example, which is a very, very good program, does not do this analysis correctly. In order to do the analysis, Revman creates some data that you have to enter in SAS. You run the analysis in SAS and then you put it back to Revman to create plots. So in Open Meta-Analyst, it's a point-and-click program. It really is a program that sits on R, and essentially it uses R routines but through a point-and-click interface. So I just opened the program and I'm going to open an existing project. And I will just navigate to where I know that I have a diagnostic test example, which is the lymph.openmetaanalyst. So when I open that, and I hope you can see the screen well. What I have is my usual spreadsheet where I have studies, years, and the 2x2 table: true positives, false negatives, false positives, and true negatives. And I am going to run a meta-analysis. And I'm going to run a meta-analysis. It asks me what I want to meta-analyze, and I will just meta-analyze sensitivity and specificity.
Can I just quickly interrupt? Is there any chance of making that window bigger?
Let me see. I am not sure that I can make it bigger. Let me see if I can. Yeah, unfortunately, I have a very, very big screen here, and I don't know if I can zoom in. Oh, perhaps I can. You know, I will put it in the other screen.
That's okay. We can see it now. Thanks.
Okay.
Thank you.
So I have selected with point and click the methodology, and there are several options here, and I can run the HSROC or the bivariate method. I'll run the bivariate method. There are options for the forest plot, etc. But these are easy to understand and summarize. And what happens is that the software runs the analysis the correct way and returns us the results. And the results are the summary point, the sensitivity and specificity. The summary point has these coordinates. These are the point estimates, 0.674 and 0.837, with confidence intervals that are shown here. And this is a calculation of the correlation between sensitivity and specificity between studies. And the ROC plot that one would get from the HSROC analysis is shown here. Now one can play with the software and get different plots and so on, but the idea is that you can use the software completely as a point-and-click interface, and it does the more complex analysis for you. So, Gerald, it's up to you on how to proceed, and I know that I have sucked up all the time, but I will be able to stay on the phone for several minutes.
Okay. Well, thank you so much, Tom. That was really an excellent presentation on a very complex topic. Let me ask quickly, are there any questions here? Kylie?
Okay, so this is a question, I guess, a little bit based on reality. So the bottom line is, therefore, the methods for comparing tests